let's see what we got here with this case. This is a 50-year-old woman with dyspnea, history of hyperthyroidism, childhood asthma. And by the way, I think a lot of our patients with PH get diagnosed with asthma before they get diagnosed with PH, especially when there's a little clue like a history of childhood asthma. She had Raynaud's for a long time, mild sclerodactyly, dyspnea for about a year that's been getting worse. ANA is high, BNP is 108. She's seen a rheumatologist that confirms the fact this is scleroderma. I think most of us would get that. Walk distance is 412 meters, okay, but certainly not great. O2 sats 98% during the walk, decreased to 95, so they decrease a bit, but certainly she doesn't need oxygen. Other labs normal, an exam, a pretty typical exam for scleroderma. She does have a few crackles, so exam sounds like there's PH and maybe something else going on. Could she have some left heart disease, diastolic dysfunction, ILD, something like that? There's some PFTs, so really not too impressive. Mildly abnormal, mild restriction there. DLCO is a little bit low. So not severe obstruction and not severe abnormality, but restriction like you might see in pH, right? You see restriction in pH. And why is that? I don't know. I mean, you get a lot of vessels that get dilated and thickened and abnormal. You get millions of little vessels in your lungs. They get dilated, they take up space, and you get restriction. She had some telangiectasias. I always look for these on exam. I mean, sometimes you're not sure if someone has scleroderma, what the cause of their pH is. We all get telangiectasias in our face and our chest. We get older. We don't get them on our palms. And I always look at people's palms, and if you find a couple telangiectasias on their palms, there's something wrong. It's scleroderma, limited scleroderma, something going on. Not usually this dramatic. She had a chest x-ray, showed mild cardiomegaly. EKG is normal. pH was now finally suspected after a little bit of a delay and some visits, and an echo was performed. So let's put the echo up here. Okay, so we got a TR jet there. So you don't always get a great TR jet, but you can see the little cross down there in the left-hand corner there, where they're kind of marking the TR jet, and it's a little more than 3 meters per second or something, and you calculate that out, right? I think that's calculated, and you can see how there's already error introduced into this equation here. Estimated pressure, say 3.3 meters per second squared, Bernoulli equation, times 4, and you add right to a pressure, you get 49. But you can imagine if that 3.3 is changed to 3.5 or 2.9, if it's not exactly right, then you're going to get an exaggerated abnormality when you square it. So you always have to be careful with that. So 49 is not so high for systolic pressure, probably not normal. RV looks like it's a little bit on the big side, so here's the echo. So we only get this one view here, but I think what you can see is the RV might even be apex dominant. RV's a little bit big. I think it's pumping pretty well there. It looks okay. The LV looks normal. Maybe I'll ask Val, you're a cardiologist. I'm going to rely on you. So not a normal echo. What do you think?
No, I think the RV's big. First of all, the RV's thick. You can see the RV endocardium a lot better than you should. So there's some amount of RVH there. You saw, Vic pointed out how the RV starts to take over the apex from the LV. That shouldn't be the case. That RV is big, and it is quite dysfunctional.
Yeah.
So I think the other thing I want to highlight there is that when you talk about the potential errors for estimation of PA pressure, you always have to look at the RV as well. So, if this RVSP was lower, and I looked at that ventricle and I'm like, I don't know that I believe that. Whereas if you get an RVSP of 60 or 70 and the right ventricle is stone cold normal, you worry that it's overestimated. So the two really go hand in hand.
Yeah, that's great, Val. You really got to put some thought into this. What additional tests we performed? You guys have already got this down. I mean, we already said they had an X-ray done once. PFTs were already done. Would you want repeat PFTs? Maybe, but I think we got a room full of people going to do a right heart cath. I think that's great. I think this room full of people is going to do it right. I think we're good here. So let's look at the CT scan that we got here. Do we need a CT? She has crackles. CT's not normal, right? I mean, there's some reticulation, some a little bit of ground glass. Let me just run through it here. So maybe a little motion artifact, but ground glass, not normal. Let's see if we're getting on the lower lungs. We're not seeing honeycombing, right? I don't see honeycombing here, but there's clearly something going on. If this is scleroderma, is it fibrotic NSIP, non-fibrotic NSIP? Is it something? But Rich, you're a pulmonologist. What do you think about the CT? Any strong feelings here?
Yeah, it's quite abnormal. I mean, you have ground glass. You can see sort of mosaic perfusion with PAH to some degree, but this is a little bit more than I might expect. You do see some septal thickening, so you might at least worry a little bit about fluid, and we know scleroderma patients can get PVOD, although it also could be scleroderma lung disease. So it's sort of a non-specific CT scan. I don't see pleural effusions. I'm a little concerned by that you said SCL70 positivity, which suggests more the systemic or diffuse more than the limited. So maybe a little higher likelihood of having actual lung involvement.
Sure. Yeah. I guess could there be some left heart disease and a little bit of left heart? We need more information, like we said. We do want to get a CAT. Would anybody do a lung biopsy on this patient? Remember, the stats were pretty good. She doesn't need oxygen. PFTs were mildly restricted. Would anybody biopsy her lung? Any guys? I mean, everyone's shaking their head no. What do you think?
I would be worried in the setting of possibly abnormal hemodynamics. We don't know yet that a lung biopsy would be associated with high morbidity.
Yeah, so you want to get a cath too. Yeah, I'm with you on that. So let's see what we got here. Well, a few more slides here. So what you can see here is, again, you can't see very well there. I didn't show enough mediastinal cuts, but there was some enlarged lymph nodes, nothing really scary looking pathologic, but like you might see with scleroderma and ILD. And our PAs look a little bit on the big side, right? So again, this fits the fact this patient likely has PH. Did another walk and around the same period of time. So between 399 and 410, functional class 3 symptoms. So here's our right heart cath. Mean PA pressure is pretty high, 64. That's way up there. PPR might have been a little higher than that, but mean PA pressure is okay. Cardiac index is low, but not below 2. Mean PA pressure greater than 20, cardiac index less than 2. We'd be thinking maybe being real aggressive. But any thoughts about those cath numbers, Val?
Wait, I just want to comment how the echo totally underestimated the RVSP. So
Right.
you didn't see that jet well, and it was
Yeah.
probably going down
Yeah.
far. And those hemodynamics are more consistent with the way the RV looked than the estimated pressure that you
Yeah,
got.
that's really important. That's really important. I mean, the mean PA pressure is higher than the PA systolic was estimated on the echo. So pretty significant pulmonary hypertension.
But can I say, as a
Please.
meager
Oh.
cardiologist here,
Yeah.
who recognized that those lungs are abnormal, but
Yeah.
couldn't give that's more pulmonary hypertension than you expect to see for
Yeah.
junky looking lungs.
I think that's the real point here. So we are seeing ILD. I'm not sure how you guys would feel about treating this ILD. We want to talk about treating the PH right now, so I'm glad you guys are focusing and thinking about that now. But what about the ILD? Would anybody treat this ILD? We've got a little data out there in scleroderma with ILD, not a ton of data. I think none of us could say there's an evidence-based recommendation. I'd be inclined to use self-CEP before I'd use cyclophosphamide. What I consider rituximab, some small studies. The ongoing study right now, NIH, still ongoing, the scleroderma rituximab study with PH. We'll get some results, I hope, next year. So there's some things we're learning, but I will say, my opinion, most patients I see with scleroderma and PH that have some degree of underlying ILD, we usually focus on the PH, maybe because we're PH docs. What do you guys think about that?
I mean,
Rich?
I'm still worried about PVOD in this patient.
Sure.
With the small effusions and that ground glass. And just for the audience, remember, in PVOD, the wedge pressure is normal. That's how we distinguish from left heart disease. Even though we call it veno-occlusive disease, it's microvenular, so you have a normal wedge pressure.
In some segments. I mean, you can get some segments where it's abnormal.
You can if you have larger vein stenosis, but in general, that's the teaching point, is that a normal wedge does not exclude PVOD. Yeah.
And that might explain the septal thickening that we saw on the CAT scan.
Sure, PVOD is a tough diagnosis. So I guess what some of us might do is say, well, this could be PVOD. I'm not going to do a lung biopsy, but maybe I'll carefully initiate PH medication and see how they do. And if they get worse and they get more crackles in their lungs or something, or they start to have more symptoms, I might be very careful and consider backing off.
Did you give us a DLCO in this patient?
I did. It was a little bit low, but not really low. I think it was 68%. So it was low, not normal, but not really bad. Considering the ILD and the level of pH, I would expect a much lower DLCO.
Right, and PVOD,
Yeah.
we see a really low
Sure.
DLCO.
Yeah, so that's a concerning point, for sure. So I think focusing on the pH here, I kind of like our audience is focusing on being aggressive up front here. This patient clearly has bad pH. Are they bad enough for prostanoid therapy too? Should they get an IV prostanoid therapy? Cardiac index was greater than 2. Mean RA pressure wasn't really high, but I would keep a close eye on this patient. Would I maybe consider parenteral therapy at some point? Possibly. So,
Can I ask a question again?
Please, yeah.
As the meager cardiologist here, do you ever worry about VQ mismatch when you initiate pH therapy in patients with?
I do, Val. That's one of the things I would think about here. One of the things, Rich's idea, could it be PVOD, or is this just someone who you're opening up some vessels, you're getting them open up, and they're leading to bad areas, and you get more hypoxemics. It's another issue. So these are tough cases. I would have a low threshold. In this case, what I'll tell you, that happened to this patient, got treated with double upfront therapy, as you guys suggested. The patient improved, but there's still concern about the ILD, and developed a little more hypoxemia, was ultimately started on CellCept 500 twice a day, increased subsequently, and as of right now is doing okay still. So we'll wait and see what the rituximab study shows too. Thanks, folks. Great job.